I think we're good to go, right? Good. Well, good afternoon, everyone, and welcome. My name is Christian Thrasher, and I serve as the Senior Director of Substance Use Disorders and Recovery at the Clinton Foundation Health Matters Initiative. It's my honor to serve as your moderator today to this afternoon's panel on health equity as part of this week's Design Sprint for the Verizon and CGIU 2021 Social Innovation Challenge, which I know promises to be a great discussion with our three panelists and all of you. Making up our panel today, we have Dr. Rachel Berval, a current resident physician and health consultant for the University of California, San Francisco. Rachel is particularly passionate about addressing health disparities within obstetrics and gynecology and reproductive health, as well as family medicine. Welcome, Dr. Rachel. Second, we have Rachel's brother, Joel Berval, who is currently a second-year medical student and also serves as the Medical Student Council President at Washington State University. Now, Joel has developed a strong following of over 100,000 followers on social media and over 6 million views on TikTok for his videos addressing racial and ethnic health disparities. And finally, welcome, Joel. And finally, on our panel, we have Kathy Lester, who serves as the Executive Director of Health Transformation at Verizon. Kathy is a thought leader in Verizon's advanced technologies and innovation and healthcare practice and is an expert in virtual care and telehealth solutions. So this session is going to explore not only the scope of health inequities within the United States, but also how we can leverage leading edge technology to address the inequities. So to begin, I would like to take a minute or two to sort of frame the issues that we're going to be talking about today. Now, the World Health Organization defines health inequity as systematic differences in the health status of different population groups, and that the social determinants of health, which are broadly defined as where we as individuals were born, we play, we grow, we work, we live, we age, and I would actually add to that where we worship, oftentimes contributes to disparities in health and access to health care. Now, health disparities, as we all know, these are preventable differences, right? In the burden of disease, injury, violence, and opportunities to achieve optimal health. And health disparities are typically experienced by socially disadvantaged populations. These inequities, we know they have a significant social and economic cost to both the individuals who are experiencing them, but also to society as a whole. And ironically, they're shaped and influenced by political, social, and economic forces. Now, thinking about Robert Wood Johnson, who's been out there, from day one talking about health equity, they say that health equity means that everyone has a fair and just opportunity to be as healthy as possible, and that no one is disadvantaged from achieving this potential because of their social position or any other socially defined circumstances. So that having been said, how might we leverage next generation technologies, things like 5G, big data, AR, VR, artificial intelligence, to improve equitable access to healthcare and health information for our underserved? These are all the uns, right? These are the underserved. These are like the and underinsured, the underrepresented, uninspired, untrusting. The list goes on and on, uninformed. What we're talking about are people of color. We're talking about the LGBTQ plus population. We're talking about, people with disabilities. We're talking about our aging populations, indigenous peoples, immigrants, those in rural America throughout the United States. Said a different way, how can we best help individuals from these underserved groups attain their full health potential? So let me begin with a question for all of my panelists today. In your opinion, what are the most pressing social barriers to equitable healthcare in the US? And sort of to go a little deeper on that, why and how do you think the disenfranchised communities that I just mentioned experience these inequities more than others? And I want to start with, Dr. Rachel. Why don't you start us off?
Well, first, thank you so much for having me here. I think I want to start by focusing in a little bit on OBGYN care and reproductive health care and kind of how those disparities have exposed other components of um, basically fractures in the way that our society is able to serve populations that are underserved, just as you described, Christian. I think it's really important to really understand that for any country in the United States, and not any country in the world, excuse me, a lot of our health data is used to really measure us against other countries and tell us how that country is functioning. Um, it's shocking when you start to understand that the US spends at least twice as much per capita on healthcare compared to any other Western industrialized country. But yet we continue to have some of the widest disparities in health outcomes. And this becomes even worse when we look at reproductive health and sexual health. And I'll hopefully have a chance to discuss this further later on. But when we really start to dissect the data and we try to understand why the US continues to lag behind its counterparts, the UK, Germany, Australia, Sweden, South Korea, Japan, et cetera, it we really start to see that our underserved communities are mistreated, and it often comes from racial biases. It comes from biases and in the systems and the structures that we have, that we kind of take for granted. It comes in the isms, the sexism, the classism, the racism that is really embedded in the way that our country functions. And it's really played a detrimental role to how we can provide equitable and equal access to healthcare to all populations, right? And so that's really the root of the issue, in my opinion, why there might be these fractures in healthcare when we are trying to reach underserved populations. That being said, and I know that we're going to go into more specifics during the 30 to 40 minutes we have together. That being said, it's important for us not to be discouraged, even though there are certain things that are embedded in the framework of the United States and our society, even though I'm saying that racism plays a big role in why we see underserved populations not accessing equitable care. That doesn't mean that we can't fix the issue, or we can at least try to make progress towards equity and soon justice, especially when it comes to health care and our well-being. And I just, before I end my answer here, I do want to say that I personally believe that this panel is incredible, and the fact that we can talk about healthcare is so important. Like I said, countries are measured by how they're able to prevent morbidity and mortality. But if you really think about it, before someone can be an active, engaging citizen, before they can be part of economics, politics, education, the list goes on, any other field, they have to be healthy and they have to be well. If you are not healthy, if you are not well, if you're not treated fairly in that component of your being, there is no way that you can be a active, engaging citizen of our society in a way that allows us to be successful, to be happy, to have families that are beautiful and really reaching whatever we are aspiring to. And so I think that I'm really glad you were trying to figure out what we can do for underserved populations so that everybody has equitable health, because when everybody has good health, then we're able to have a society that's functioning at its highest level.
Thanks so much, Dr. Rachel. Two things jumped out at me in your answer. The first is I very much appreciate how you're defining health more broadly: physical, mental, spiritual, sexual, kind of the whole person. The other thing that stuck out to me was this whole idea of isms, right? And I heard once It said that an ism is really I, self, me. It's only thinking about myself. It's based in total self-centeredness. And our lawmakers are often some of the biggest perpetrators of isms because they're not thinking about their constituents. They're thinking about themselves and the people that unfortunately have influence with them. Same question, and if you need me to repeat it, I'd be happy to do so, but I want to go to Catherine. Catherine, what are your thoughts about how disenfranchised communities that we are talking about experience these inequities more than others?
Absolutely, and I'm pleased to be here. And Rachel, such good insight. I would tell you there is an interesting realization that we came to during the COVID pandemic regarding access. The digital divide is pretty apparent. So we're seeing that there are underserved communities across our ecosystem, some of which are really being represented by those smaller rural communities where there is either not access to the entire spectrum of specialists, or geography is a real limitation of being able to connect with the right care at the right time in the right place. We see that not in the rural communities run across the spectrum. So those can include seniors who may not actually have devices or that comfort level with using devices. It can be the veteran community, which tends to live a little bit further out, a little bit further off out of the what we would consider a highly population. That's not everybody, but looking at some of those statistics about who has the devices and who has the connectivity to make sure that what we have is that ability to access those resources, in addition to having the right and the opportunity to access those issues or to access those services that go through. So I think that's tricky. Many things, and again, as Verizon, one of the things that we want to look at is expanding coverage maps and access types of things. The one thing we do want to keep in consideration for our students that are looking at innovation is you have to account for that when you're developing. You have to account that everybody has there's varying levels that we have to be able to account for access, devices, multiple things. It's not, you have to really understand that community you're working in.
Totally true. Yeah, the digital divide is something that we need to talk more. We're going to get to more of that a little later.
Yeah.
Thanks so much. Joelle, talk to us about your sort of experiences with this. We talked about how many impressions you have using social media, talking about these issues. Where do you come at this from?
Yeah, first of all, thank you so much for having me here. And Rachel, Catherine, great intro to kind of understanding some of these social barriers. I kind of want to reiterate, Christian, what you were saying about the social determinants, the things that are often barriers to people actually getting the care they deserve. There are things like economic stability, whether you're able to actually feed your family and have time to go to the hospital. If you don't have the economic standby to even be able to think about other things, health might not be the first thing on your list. It's education and health literacy. For many people, if you don't actually have the knowledge to understand how do you read a label on a bottle that says how many pills you need to be taking, or if the doctor tells you a cancer diagnosis and you don't totally understand what that means or the care you have to go through, that can impact how the care you receive and whether you are willing to even go back to that doctor, whether you want to engage in the system at all. You can think about the social and community context. And Catherine, I love that you talked about rural communities, that different, it depends on where you are. The community you're in defines the access of care that you can get. Telemedicine for some students may be something that you're thinking about as a way to maybe fight these barriers. And it's a great idea because in many rural communities, there might not be a physician in your area that can treat your specific diagnosis, whatever you have. And then you just think of health and healthcare overall. How do you actually look at pre-existing conditions and not wait till you actually have the disease, but maybe things that you can be doing beforehand, whether that's healthy eating or gyms in the area, or making sure that there's parks and areas to walk around. Then you think about the neighborhood and the built environment too. So for individuals with disabilities, are you able to get access to areas that you need to go to? If you're on crutches, are you able to go into different places? Are buildings up to code? All of these things are within the social determinants of health. And each of these can be barriers for people when they actually go into care. And there oftentimes there's not even when you get to the hospital, it can be before or after you're at the hospital as well. The other thing I'll say about social barriers is that they often rise when people aren't brought to the table, people that look different. And in medicine, that happens so often. One of the things I talk about on my posts on TikTok and on Instagram is about things like pulse oximeters, which are machines that measure your blood oxygen saturation level. And unfortunately, when they were designed, they didn't take into account people of darker skin, or they didn't do enough studies. And so there actually is an overestimation when you use a pulse oximeter on many people of color, meaning that you come in, you might have shortness of breath, your reading might actually be 92% oxygen, but the device will show it as 98%, overestimating what you might have. And things like that, which is not tested on different populations. It's not just for people of color, but it's also for women who often weren't tested on in clinical trials. It's for people of the LGBT community and understanding maybe biases and why is there disparities and wanting to go to the physician. All these types of issues need to be taken into account. And often those that are marginalized are left out of that conversation.
So true. Social barriers are inextricably linked to culture. And you clearly are sort of headed in that direction when you're talking about all these different social determinants and the impacts that they have. So let's talk for a moment about trust within the healthcare system. Before I came to the Clinton Foundation several years ago, I spent 14 years of my career at the Morehouse School of Medicine and HBCU, teaching medical school in Atlanta, Georgia, and worked with many of our medical students. And over that time, many of the medical students went through what we call the crash course on cultural competency. And this crash course was to help our future physicians and health professionals be more culturally competent. CRASH is actually an acronym. The C in CRASH reminds us to consider one's culture. The R reminds us to show respect. The A in CRASH is about assessing and affirming your differences. So as healthcare professionals and providers, recognizing our differences from the people that we serve. That's so important. And the S is to show sensitivity and self-awareness. And finally, the H tells us to do it all with humility. I always say that everyone teaches and everyone learns, and to remain teachable. So given that just 5% of the health professional workforce are people of color, it's imperative that cultural competency is a reality for our healthcare providers and professionals. So as health professionals, how can we ensure that one's culture is front and center in the care that they will ultimately receive? And I'm going to lead with Joelle. I want to kind of switch up the order. I know we just heard from you, but Joelle, since you touched on it kind of last, talk to me about how you think this unfolds.
Yeah, I think that's a great question, and I don't even know where to begin. I think, like I just talked about, the social barriers that kind of lead into this can impact people a lot. So I'll just use my personal story. Even in my medical school, I'm one of 3 Black students in the entire student body. I have 280 students. And I think oftentimes when you're not able to see someone in a position that you can get to, that can manifest in less people of color actually going into that field. For me, my first experience that kind of pushed me into medicine was seeing physicians at Howard University Hospital, an HBCU. And so I think it's undeniable that when we look at the numbers, only 5% of physicians that are Black specifically, I think it comes from needing to have more mentors in those spaces, but also realizing that it's a problem in the first place and creating resources, because there can be a problem either getting people in the pipeline, either getting people to retain in the pipeline, or getting people to bring others after they come through. And I think medical schools need to do a better job of talking about these issues, that there is a problem, and also recognizing that it has a direct impact on our workforce and on the patients that we serve. In medicine, you're never going to see 2 patients that are alike. So in order to treat patients that are from different backgrounds, you need to have a representative workforce that represents that as well.
That's great. Dr. Rachel, talk to us about, you gave such great examples of OBGYN and sexual health, but talk to us a little bit, how you think culture is front and center in the care that our patients will ultimately receive.
Absolutely. I think we focus so often on that 5% number. 5% of physicians are Black, 5% of physicians are Latinx. This is a huge disparity when looking at the entire population, recognizing that 15, 16, 17% of our population are from both of these ethnic backgrounds and racial backgrounds, respectively. That being said, I completely want to echo what Joelle said. Representation matters. You see one, you believe you can do it. But where we stand right now, that's not feasible. There's 5% of physicians that are Black. It is not possible for every Black person in the United States to have a Black physician or provider at this moment, even though we are working actively towards it. And so for me, where culture comes in is with the topic and the idea of cultural competency. And cultural competency is this framework where you have someone who is different from you, but you are able to understand and listen to their stories, their background, why they are coming to you, why they might not have come to you, why they are hesitant about a treatment plan, or what barriers are in the way of, seeking out their entire management, right? But I think then we have to hop from competency to cultural humility. And that's the hard part. That's the part where we're able to identify our own biases as providers. So yes, I am a Black doctor, right? But when I have a Black patient, even though they might feel comfortable coming to me and that level of racial bias is broken down because they're speaking to someone who looks like them, I still have to humble myself, have a sense of humility, and recognize whatever biases I'm bringing to the forefront that's going to change my interaction with my patient, or make me think about how I'm going to deliver my care differently, right? And I think that that's the really important part when we talk about culture in medicine, is how are we first able to recognize everyone's different, just like what was said, but recognize how we have to recognize our biases and have a sense of humility. And I think that making sure that you recognize there's so much intersectionality when it comes to providing healthcare.
You remind me, Rachel, of a very, very brief story of how culture affects the medicine that we provide. There was an African-American over-the-road truck driver that went into his physician, and the language that he used to describe his ailment, he said, I almost feel like I have the devil over here on this shoulder and an angel on this shoulder, and the devil keeps on telling me all these things to do when I'm driving across the country. And his provider was not African-American and diagnosed him with schizophrenia. And he grew up in the church, and that was the language that he knew to describe what was going on with him. But he wasn't saying that he heard voices. It was, he was using his culture, his language, his norms, and it was just totally misinterpreted. So there's just another example to emphasize or reemphasize what you just said. Kathy, you had mentioned the digital divide in the beginning, and I want to sort of do a little bit of a deeper dive with you there, because in many ways, the future of modern medicine, and certainly when we think of rural America and the challenges that come with all of that you mentioned, talk to us a little bit about the issues of access. You had mentioned the veteran population, but they have mounting needs, we know, but what do we have to look forward to in this space?
Oh, we are in a medical renaissance. So when we start looking at that intersection of how technology is going to influence healthcare, it's a magical time to start looking at innovations, especially when we're looking at those populations that may not be in urban centers. So one of the really interesting programs that we're working with right now is around connected ambulance. So when we start thinking about how do we address specific care pathways, stroke, long transport times going from rural communities, air ambulance types of ecosystems, how can we actually look at community paramedicine, bringing care to the community where it's appropriate, and then breaking down those barriers and say, look, I can do this remotely. We have seen that we have that capability and that technology to be able to do that. That does require access. So we do need to, and there's big efforts underway to make sure that we're expanding into those those areas of coverage so that there is an equalness. Interestingly, remembering when we start looking at development or development processes, one of those key things to remember is the surrounding situation. So we've talked a little bit about access, but we have also need to hint on when we talked about telemedicine is what are we looking at for elements that may be around translation or English not as a proper language, as a first language, as your primary language. What does that feel like? I love that we have an ASL interpreter. This is a wonderful resource, but how do you do that in the back of an ambulance? Right? Most of you, as an EMT, I'm not trained in sign language. So if I have a hearing impaired patient, that's we're going charades. We're going to try and we'll find a way to communicate because we'll always find a way, but it's a little bit trickier. So being aware of those elements and then leveraging the entire ecosystem that we have to pull from to bring in an ASL, to bring in another translator in a on-demand video teleconference with a health provider. We can do those things. And that actually brings it back to that cultural competence and that cultural sensitivity. I would tell you one of those things that we see at Verizon all the time is we've really integrated in an absolute removal of bias, or at least a check on bias. That says when we're doing product development, and Joelle had a wonderful example on the pulse ox, we're seeing some really innovative technologies coming through that are measuring like vital signs off of body cams on EMTs, just using your face. I don't passive monitoring. I don't need different things, but those are different on every population. The stickers, the vital tag type of program that allows me to do a tag and track and maintain a vitals connection that's relayed ahead of transport in the back of an ambulance. Again, different on every single person. So really making sure we're expanding those elements to include everybody. Then it doesn't matter, right? We want to try, and at least right now you're seeing everybody's aware, right? Everybody's aware of this and how do we test and what do we do? So I would tell you it's amazing. And I'll say one more thing on the vitals tag. Can you imagine if I go to a hospital and then I come home to my rural community, imagine I could put a patch on, right? That would actually monitor my vital signs that could be combined with other things that would actually extend that hospital care system into the home, right? How would that change things? So I'm not on an island when I leave the hospital hoping for the best and saying, I think I understood what he said about to everybody's one. I think I understood I'm supposed to take 3 of these, 2 of these, and a partridge over here, right? So getting that put together in more of an interactive scenario could be game changing. And then it doesn't matter. And again, get rid of the access problems, add in that color blindness and that population, whatever, everybody in the rainbow population. And then really what a difference that could make.
That's a lot. I mean, we have just barely scratched the surface of these issues, and we are already running out of time. I'm going to, remind us all that this is all about the students, right? And so I'm going to ask a couple of questions that I hope will really help the students with the design sprint that they're planning, and be able to sort of recognize that all of us come at this with different experiences, right? But I want to hear from all of you what motivated you personally to pursue these issues of health equity in your work, and do you have any advice for the students that are interested in this field? And let's start with Joelle.
Yeah, I think that's a great question. And for me, what led me to really start thinking more about these issues was my personal experiences in medical school. I think as a medical student, you go through the system, and when you start thinking about it and actively looking for it, you will realize so many little places where things can be changed. For example, we're in our dermatology unit right now. So many times I've tried to look up what things look like on different skin color. Melanoma, for example. If you type in melanoma into Google right now, all the images that will come up are white. And that's significant because although people of color are less likely to get melanoma due to having more melanin, when someone that is a person of color does get melanoma, they are more likely to die. Their 5-year survival rate is 66%, compared to Caucasian populations, where that 5-year survival is 90%. And that disparity comes from doctors not knowing how it looks like on skin, patients not knowing how it looks like on skin, and technology not being adequate enough for people to look up what it looks like for them to understand. So my advice to students when you're thinking about what should I be doing is find something that makes that personal for you, that you can understand, that you've seen in your own life, and figure out how technology can kind of insert in there. So for example, with dermatology, does that mean aggregating pictures online in some way using artificial intelligence to better understand how can you look at cancer diagnosis using AI automatically? I have friends that are literally doing that right now to look at histology slides with AI, things that are innovative and that make you kind of think in a different way. So take things that are personal and figure out how can I apply technology to this to actually make a difference.
Absolutely agree. Kathy, same question. Why did you pursue this issue of health equity in your work, and what advice do you have for the students on here listening that are interested in this field?
So I had a unique opportunity to work internationally for quite some time with NATO, and firsthand experience is a valuable teacher when you're seeing what happens in very, very underprivileged areas. And it inspired me to do more work and to lean in and to take that challenges on to make sure that we can. Geography should not obfuscate care. We should not be able to not. It's just crazy when you see that live and in person. It's a very impactful experience. I encourage everybody to look globally at some of these issues. What I would tell you is my biggest advice is I'm going to take the unintended consequences. So I'll share a quick story. I did this wonderful program that was addressing seniors in care, senior congregate living, and it was gonna watch for temperature rise as we age. We were slower to show infection, so we were going to monitor some passive monitoring temperature, and we went through this whole process, and we put these sensors in, just sensors monitoring body temp, no video, no cameras. We did some initial preliminary testing, and then we came back probably 3 weeks later to talk to them, and we had found that every senior had covered the sensor with tinfoil because they were not comfortable with what exactly was being. It was probably more dangerous for them to cover it with tinfoil than it was for them just to rip it off the wall, right? It was just. So what I would tell you is we absolutely want to make sure we understand who we're addressing, we understand where they are, and that may or may not be where we are, right? So technology first does not work with every group. So we have to be very aware of what those things look like and really understand that the problem that we're trying to solve is the problem the community we're serving also wants us to solve. And really be clear about what it goes. But it's a really important thing. You have to fail. You have to see that. I was stunned. When I walked in, I was like, I missed that one by a lot. Mm-hmm. So I would go with those sort of things and making sure you really understand the community you're serving.
So very true. Just reemphasizes everything we've talked about. All right, our last word will be from Dr. Rachel. Dr. Rachel, what advice do you have for our students that are interested in this field? And let me just preface that by thanking the panel immensely for coming out today, giving your time and talking to the students. It means the world to us. I know the Clinton Foundation and obviously also Verizon are partner with this. So Dr. Rachel, bring us home here.
Absolutely. I think I'm going to start with my own personal story as well as to why I decided to even enter medicine. So Joel and I both come from a family of immigrants. My parents came here from Ghana, West Africa, and we were raised by our grandmother for a large component of our childhood. And she could barely speak English, but she was just so graceful, so beautiful in her demeanor, in her actions, and everything that she did. She really taught me what it meant to be a community servant leader. And that, what we do as individuals, even though it might feel small, we do have a ripple effect on those that are around us. Unfortunately, she passed away from poor health delivery when she had gone back to Ghana, where it's an under-resourced community when she went to the clinic, and she was asked to provide her own IV drip when she went to the hospital, which I think for us in the States would be like, oh my gosh, that's unheard of. But then you have to remember, we have things that are very similar here, right? We have the food deserts that are preventing people in communities to access pharmacies appropriately in grocery stores, or even the fact that they can't even get fresh fruit or vegetables in the first place. And so for me, that was the impetus to enter medicine altogether, but it was to really address the underlying issue, which is how do we make sure that our patients access healthcare in order to be leaders in their communities, right? Going back to what my grandmother led for me as an example. When it comes to leveraging our experiences in healthcare and making sure that we provide others around us with equitable health, I think that's where the creativity comes in and why things become really exciting and how it becomes exciting. Again, I'm very passionate about reproductive health and sexual health as an OBGYN, family medicine provider. And that's because, all of us came from a womb. All of us came from a birthing person. We all came from someone with a uterus. And so it's important for us to take care of those that are women who oftentimes identify as women in our households, and make sure that they are treated well so that they can take care of their family structure. I think of a really amazing project that leveraged technology in order to make sure that there was gender equity and also health equity. And that was I believe it's called the iCut program that was trying to address female genital mutilation. They made this app. It was a group of 5 or 6 young girls in high school. They made this app for people who basically were going through FGM, fetal genital mutilation. And it provided these women access to legal care, right? It provided them access to health information because there was a disparity in understanding what sexual health was and what it meant to go through this horrific procedure. It provided them a social worker or access to a social worker, especially when they might feel ashamed to speak up and talk in a society to their loved ones, to their family members. And so I think, coming all back to square one, it's this ability to say, how can we make sure that this person has the confidence to, again, be a servant leader in their community, but how can we make sure we're addressing the disparities in their healthcare that is really, really bringing them down altogether? And so I think that's my answer for a lot of different components of your question. But I think hopefully that inspires someone listening to really dig in deep and try to change the communities and the health of their society, one person at a time.
Wow, you talked about leadership, and all three of you are leaders. When I think of leadership, I think of this whole idea that leadership responds to opportunities, to challenges, to crises. Leadership is a team sport, right? It's not position dependent. But it can transform communities. It's like a relay race in a sense, that I run for my part and then I hand the baton to the next person coming up behind me. But I heard it, the Institute of Medicine actually says that leadership is too important to leave its emergence to chance alone, that we have to be very deliberate about creating the next generation of leaders. And I think, this partnership with Verizon between CGIU and the Clinton Foundation is doing exactly that. Joelle is an alum of CGIU, right? And so, yeah, this is about you all. This is about leadership. And so on behalf of the panel, we encourage you to go out and lead. This has been a great, great panel. I'm sorry, we have so many more questions. We could do this for another 3 hours, but unfortunately, time does not allow. So on behalf of Catherine Lester at Verizon and Joelle and Dr. Rachel, thank you for being a part of this. And we look forward to seeing what you all do. So have a great afternoon.
Thank you all. And for those who are, I know there's a lot of questions, but for those who want to know a little bit more about OBGYN or reproductive health care, you can follow me on the Black OBGYN project. We can continue our discussion there. Shameless plug.
I do want to also say, if you have some questions, we will be having an office hours panel as well. So be on the lookout for that. If you want to attend, talk to us more directly. We can try to answer questions there that we didn't get to today.
I'm muted. Story of my life. We have a few more minutes before they go into their next session. Is there any Q&A that anyone picked up that they want to take a stab at? I'm just seeing them now for the first time. How do you think microaggressions, racial biases affect the treatment or under-treatment of pain in sickle cell disease patients? What do you think can and should be done about it? Joelle, Dr. Rachel, do you have any thoughts on that?
Yeah, I can take a start. I'll try to be brief. I think not just talking specifically about sickle cell, but just pain in general. There's a very long history of biases in medicine and medical racism that unfortunately has contributed to today's disparities when it comes to treating pain appropriately. We go back to the mid 1800s when there was this false idea that Black people could endure more pain than their white counterparts. Even though that has been debunked, unfortunately, that presumption and that myth persists today. In 2016, the Proceedings of the National Academy of Sciences actually did a research study based at UVA where they had surveyed over 200 medical students and residents, and they found that over half of these trainees actually believed or attributed some sort of myth to and difference to Black individuals, Black patients versus their white patients, whether that was Black patients had thicker skin, Black patients were less sensitive to pain than white patients. And unfortunately, that research study showed that those responses had direct implications and consequences on how those providers and future providers would subsequently provide pain management. That same idea can be true and said about sex differences, where there's this idea of hysteria. Even the word itself comes from a very long history. The root hist being the root meaning womb. But where people feel like women coming to the ED are over exaggerating their pain symptoms. And so they are treated either less than their male counterparts, or they are treated after complaining for a longer period of time. And so all of these biases taken together can really make a difference when it comes to medical conditions like sickle cell disease. Sickle cell disease, as we know, is it predominantly affects Black people, not all the time, but it predominantly affects Black people. And because of that, you will have someone coming in with an acute pain crisis saying, I need pain medication. And maybe this bias that your provider has that is implicit, they're not doing it on purpose, hopefully, they don't mean to not want to treat you, but something in their minds like this person might be exaggerating for whatever reason. And that would prevent that person or individual from getting the treatment that they actually adequately need. So, I think there's a lot to be said when it comes to these type of questions. What can be done about it? Obviously, education. I'm a huge proponent of education and making sure that we are discussing this early in our training, because a lot of people don't recognize this issue and these biases until they are providers themselves. But starting as a medical student, starting even before medical school and trying to understand where you are coming from. And again, going back to that humility side, being able to know where you're coming from, but address it and tackle it and confront it is really important. But I'm sure there's other ways as well to really address these type of issues.
Brilliant. Joelle, I know you typed the answer, but we didn't get to see it. What is the answer with the Pulse Ox? Are they developing Pulse Oxes for people of color?
So what I've heard is that there are some companies out there, and I apologize, there's a loud noise outside, but there are some companies out there that are working on it and that think they have some workarounds, but I haven't seen anything widely available on the market. There's also, I think, some companies looking at ways to get around even using infrared light. So not having to even go over the finger, but instead looking at different methods to measure that. So from what I know so far, and it might just not cross my radar yet, there isn't anything out there that's widely available that takes into account darker skin and has adjusted for that correction. And of course, a study would have to be done after those are created to make sure that that it is accurate for all patients.
Mm-hmm. Yeah, no, that's great. Catherine, any parting thoughts or words? You know, it just dawned on me, we didn't even touch on COVID-19. That might be like the first time in the last year that I haven't discussed COVID-19. So, but Catherine, any parting thoughts?
I would tell you is just remembering that when we're sitting at that intersection, there are so many new things coming down the pike. Think about immersive, think about augmented experiences that can both drive education, it can drive patient experience. There's some really interesting elements that can help activate communities so that we can take some of the fear away. A lot of things are fear-based. As a cancer survivor, I would tell you that first chemo treatment is terrorizing. It's a terrorizing experience. So imagine if you could eliminate some of that fear by having an immersive experience so you know what to expect. Would that help you process? Would that help you train? Would that help you give things a voice? Because, you know, those transitions, that behavioral impact, all of those elements. So I would encourage everybody to think about those things that are near and dear to your heart. Think about that passion. Think about what it is that could make a monumental difference. But don't think it has to change the world. There are some things that are magical. Just think about the pulse ox. That is not a complex device, right? I mean, it's an interesting device, but think about how much that changed what we do for treatment. So I think Dr. Rachel said it brilliantly. We're doing it one patient at a time, one step at a time, one move forward. So big aperture. Think about what could be.
But Catherine, I want to follow up on that a little bit.
Yeah.
Because digital health moves so quickly. So how do we find the balance between recognizing that, like in public health, we want to back it up with the science, right? So we want to be informed by the best available public health science before we make the move. And we've seen this now. I am getting into COVID-19, right? We've seen this with vaccine hesitancy and I mean, all these different examples of like, if people feel like the science moves too quickly, like a lot of people didn't know that they'd been working on a vaccine for 6 years. They pivoted to COVID, but we had MERS, we had SARS. It's not new, you know? And so, you know, how do you find the balance between digital health that's just like this and public health that's like, let's be pragmatic, let's slow things down, let's make sure that we're doing this right, let's make sure we're involved or informed by the best available public health science. How do you find that balance from a digital health perspective?
I would tell you, I think a lot of that actually is we have an interesting innovation, technology, policy kind of spread. So we have some things that are moving super out. We can develop things quickly, and there's apps and there's different things and wonderful stuff, but it takes a long time to get them through regulatory process and different things. So what I think we have is we have an unequal hockey stick. It's not quite the same that how things are moving along quickly. I would tell you that a lot of times we're seeing pathways coming through on wellness. So more of a wellness type of application that's coming through to test, validate, verify, more screening rather than clinical diagnosis to really find out, does it work on everybody? What is the information we're getting? Is it scalable? Because something that can't scale, it's interesting. It's just probably not helpful. But I think we have to get policy and innovation working together. I know we're up against the time that rock and rolls. I know Verizon has some hours. We're happy to talk about that as well. But we got to even it out. We got to even out innovation with approvals and regulatory and policy and and find ways to get this introduced where we have some of the science ahead of time, maybe not in clinical, but in other aspects.
Joelle, as a future physician, I got to give you a one breath opportunity to answer that because you talked about technology. You talked about being trained in medicine. Where do you see that? And then we're going to close out, I promise. 60 seconds.
Yeah, I think there are ways that medical education is actually complicit in adding to biases. So as I mentioned, talking about skin color and things like that. And I think medical schools need to do a better job of making sure that they look at patients holistically. They treat, they give education that's really making sure that you include African-American, Latino, LGBT communities in the kind of vignettes that you get. Then when we go through standardized training that we see different patients, it's the best way to better understand how we as students can treat a large population, and also figure out how do we begin kind of inserting technology into these different areas as well. So I think it comes from the schools having to diversify their whole entire curriculum more. And then I think everything else will follow with better understanding communities and their needs.
Rachel, Joelle, Catherine, I could talk to you for days. Thank you guys so much. We have to give the room back to the next panel, but thank you, and have a great day.
Thank you, everyone. Take care.
Appreciate it.